Hello and welcome to today's webinar, a CareCentrix-led panel discussion with industry experts about addressing key challenges to managing long-term services and supports. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We are very fortunate to have with us today John Driscoll, Linda Hines, Dr. AnneBeth Litt, Mike Nardone, Susan Tucker, and Scott Markovich. John Driscoll serves as CEO of CareCentrix, a $1.6 billion healthcare and tech company managing the post-acute space for health plans. Prior to CareCentrix, John served as president of Castlight Health, a health technology company. And previously, John served as group president for new markets at Medco and led product development. John has a BA and MBA from Harvard University and a Master's of Philosophy from Cambridge University in England. Linda Hines is the Medicaid Plan President for Virginia Premier Health Plan, which serves approximately 325,000 Medicaid and dual special needs enrollees for the Commonwealth of Virginia. Ms. Hines earned her BSN, Master of Science in Nursing Administration, and her Executive MBA from Virginia Commonwealth University. Dr. AnneBeth Litt is the Medicaid Medical Director at CareCentrix, serving as the clinical lead for the development and implementation of LTSS products. She is a fellow of the American College of Physicians, a board-certified internist, and an associate professor of medicine at Newark Medical College. Mike Nardone is currently consultant, providing strategic advice on Medicaid health policy and long-term services and support. He has more than 30 years' experience in health and human services at the state, local, and national levels, most recently leading the Disabled and Elderly Health Programs Group at Federal Center for Medicaid and CHIP Services. Susan Tucker is a certified public accountant whose experience includes extensive operational compliance and financial expertise for LTSS programs at the local, state, and national levels. She is a licensed CPA in the state of Florida. And Scott Markovich is the EVP of Markets and Products at CareSource. In this role, he oversees all of CareSource's health plans and leads product strategy as it relates to managing individuals with complex needs. Scott has over 25 years of experience in government-sponsored management care. At this time, I would like to turn the floor over to John Driscoll to kick us off.
Thanks, everybody, for joining. We are thrilled to be talking about how we can all work better together to meet the needs of this very vulnerable population. But maybe we'll first just do a round robin, starting with Linda, with why are you passionate about taking care of this population? Linda, do you want to kick us off?
Yes. Good afternoon, and thank you for having me this afternoon. This population is so pivotal to what we do as a Medicaid. We see this as an extension of the beneficiaries that we serve. Before moving into the long-term services and support space, our membership would drop off when they had these critical needs, and we were no longer able to have the full continuum of care. So now with servicing them in this capacity, when there is a need, they can certainly qualify for those services. If that need should change and they no longer need that extensive service, and they can still stay on the health plan, with their care coordinator, with the health plan that they trust. And so that has been very important to not only us, but also to the membership.
Susan?
Good afternoon and happy Friday, everyone. As mentioned earlier, I'm a CPA and I started my career in public accounting. And one of my main areas of focus was working with not-for-profit organizations that served those who were elderly or with physical disabilities or with behavioral health needs. And so I learned really early in my career what the needs were for that population. I worked with an organization that was one of the first Meals on Wheels programs in the country and had one of the first adult daycare centers in the country. So learning this firsthand at a fairly young age, just coming out of college, really put me on a trajectory more toward the healthcare side rather than the financial side. And then from a personal point of view, my father is 94 with advanced dementia. My sister is his living caregiver, and I know from her hard work and challenges that it can be very difficult as a caregiver to provide care in the home for someone with those extensive needs. Thanks, John.
AnneBeth?
Hi, good afternoon, and as Susan said, happy Friday. So I am passionate about wellness, and I've done wellness clinically in many different forms, most recently clinically as the medical director for a multi-specialty clinic for individuals with intellectual and developmental disabilities. And at that point, I really appreciated the need, the opportunity of this vulnerable population, and really was working first on the individual level and then administratively on the community and population level, and just think that there is so much need and so much opportunity that one member at a time, one opportunity to focus on each of these individuals, get to know them, and be able to provide the resources that they need, both in their homes as well as in their communities.
Awesome. Michael?
Hello, Mike Nardone. Nice to be here today. I guess I would just echo Susan's comments about having experiences trying to take care of elderly parents was a challenge for me. And now that I'm part of the aging demographic, this is an issue that's even nearer and dearer to my heart. But also, I think just from a policy standpoint, I really became most interested in this area when I was serving as Medicaid director in Pennsylvania. Anybody who has served in that capacity knows that when you look at the charts on where expenditures go in the Medicaid program, generally populations that are elderly and disabled make up somewhere between 25 and 35% of the Medicaid population and represent upwards of 70% of the costs. So if you're looking at ways now many of those costs obviously are driven by the different needs, but if you're looking at ways to improve the program and to save dollars, it's really one of the areas you look at. But also from the perspective of people wanting to be and live in the community, it was one of those win-wins where not only could you provide services more economically, but you could also potentially save money. So I kind of got into it that way, but it's really been a passion of mine since that experience carrying into my CMS days.
Thanks, Mike. Scott, do you want to round us out?
Yeah, sure. And good afternoon, everybody. Pleasure to be here with all of you. I think, I would echo what everybody said, to be quite honest. And I think if you work in Medicaid, you're passionate about Medicaid. I think everybody on this phone call has been probably in Medicaid, at least the panelists, right? We've been doing this for over 25 years. And when you work with this population, you tend to want to work with this population because you realize you're doing them a huge service. You're trying to help them navigate. I agree with Linda. When you manage everything but the LTSS benefit from a health plan perspective, you kind of lose them after some event happens. So making sure that we bring the services, the capabilities that they need to live at home, remain at home, be in the places that they want to certainly be outside of being in a facility, that's super, super important. So I think, the passion I have is changing the trajectory for these folks, making sure they get the care that they need. And I, too, went through a situation with my father where, when he was discharged at home and trying to get all the services that he needed to remain at home and die at home, we were in a position where he was home for 3 weeks and we still didn't have everything done before he passed away. So that sort of, again, reminded me of why I'm in this business and why I'm passionate about making sure those individuals who want to remain at home can do so the right way. So I think we're all in it for the right reasons.
Yeah, no, and one of the things, Scott, that I'm reminded by Susan that's not on my resume is that I started my career out of college at the Executive Office of Human Services, working for the Department of Mental Health and Social Services, trying to work with people coming off the streets and out of institutionalized settings. And you realized how much falls apart in that last mile. It's one of the reasons why CareCentrix, our mission is to help people heal and age at home. And I think that unifies all of us. But I think in order to start to think about solutions, we need to think about the unique needs of this population that we're experiencing every day. And Linda, maybe you could talk a little bit about, opportunities, because we all know that if care is managed, it's particularly important to manage it where it's disrupted, and that's often the case of the most vulnerable populations. But maybe we could sharpen the conversation by thinking about we could identify the unique needs of this population, and then start to talk about bridges towards solutions and how folks in industry ought to be thinking about that. So, Linda, you want to take that?
And so, yeah, before jumping into just the unique needs, I mean, I think that it's helpful to paint the picture of what we see with some of the membership that have those needs. I mean, usually they have 4 or more chronic conditions. They're on 6 or more different medications. There's usually a high prevalence of behavioral health issues, as well as social barriers. Now, not all, because not all of our members are middle to elderly. I mean, we do have children as young as newborns, actually, that fall into this category on our health plan. So they don't all have chronic conditions. So, they may be disabled physically or mentally as well. But, it's to say that they have a lot of challenges and needs. And really, sometimes it's as simple as helping them to navigate the healthcare system. When you are a caregiver, a family member, and you're really trying to help your loved one and not really knowing where to turn when you need to get just maybe a specialized bed, or you still need to work while you're trying to provide that care, getting someone to come into the home, or you may be the caregiver, but you also need some respite care. And so that's a need and a challenge as well for individuals. It's not always agency staff that's coming in. Sometimes it's consumer-directed care that people are receiving. So that can be a family member, or it can be someone that the member knows, that they trust, that they want to hire to come in to help them with their needs. And so then that's another challenge, teaching them how to be basically an employer to make sure that their needs are being met, to make sure that we are advocating for them when they need that assistance. But I think the biggest is really giving them the support to stay in the community. And I think all of us have mentioned that. And that support can run the full gamut of needing skilled nursing to some light housekeeping duty, to maybe helping them to go to an adult daycare center during the day so that that person that they may be living with can go to work or have different activities. The behavioral health needs are huge. Sometimes we see the combination of not only behavioral health, but also substance use. And so then you compound that with the many medical challenges that they have. Sometimes it's finding the right provider that can deal with all of that. I mean, we really try to minimize when needed, having individuals to go to a host of different providers, because then we find that the care is not as coordinated as it should be. I think from a health plan perspective, we do need someone there to help to make sure that all providers are talking to each other, all community stakeholders that may be involved are talking. And so we do hold interdisciplinary care team meetings to help with that. But that is really something that our membership needs. If they're going to the emergency room and getting this medication and going to another doctor sometimes it doesn't always interact well together. And so from a health plan perspective, we're really trying to work with the member, work with their family to make sure that the care that they're receiving is appropriate and it's in the appropriate setting. We talked about the social needs. a lot of times, they're on Medicaid, and so unfortunately it is lower income. And I can tell you that the pandemic had a great impact on this membership. Being able to stay in their home, the people that they relied on to provide care for them no longer wanted to come into their homes. However, the need did not go away.
Yeah.
And so trying to find, sometimes now instead of having one caregiver, we're pulling together 2 and 3 different people just to help that person stay into the community. And last, I will say the other unique need is when someone goes into a nursing facility, the goal is not for them to go into a nursing facility and stay there forever if we can help it. But what we do find is the longer that someone is in a nursing facility, their support system in the community dries up. And it is harder to transition them from the nursing facility back into the community. So, we really need to start on day one. If there's a desire for them to return home to the community, making sure that we have all of those support systems in place and ready to go, that when they complete, whether it's therapy, wound care, whatever it is, that they are able to return home safely and in the time that they want to return.
So, Mike, as a former Medicaid director, how do you respond to that? It sounds kind of overwhelming.
Well, it is overwhelming a little bit, but I think that as I was listening to what Linda was saying, I think the one point that really came through to me when you're talking about the LTSS population is you can't speak about them as a monolith, right? Each person has their own unique needs, and really the challenge to the system is to be flexible enough in order to be able to address those needs. And I think it really does go to the person-centered care plan, which is part of the requirement for Medicaid home and community-based services, to really to help the individual, to help to meet the needs of the individual. I think Linda also points to, the importance of social determinants of health. And, I think that's something that I think the healthcare, our healthcare payers have really, and government has basically come to see the importance, the importance of that. And as someone who used to lead the homeless services system in the city of Philadelphia, I have to just mention the critical need of housing in all this in terms of long-term services and supports. When Linda mentioned the point about how the longer someone is in a nursing home, the harder it is to reconnect them into the community. One of the places where that really shows itself is in the housing arena. And the ability to maintain a home becomes much more difficult if you're in a nursing home for 6 or 8 months, if not impossible. So it is an overwhelming challenge, but I think that to the extent that we can provide the care coordination that's required, to see the person as an individual and work to coordinate across the different systems in order to allow an individual to access the needed services, both medical and social. I think that's important. And just one final point I would make is, I think one of the challenges is bringing in the community-based organizations which are located at the local level. These are folks that typically have a lot of expertise in some of these social needs, and so making sure we kind of break out of the medical model, particularly when we're dealing with LTSS, I think is really a critical factor. And I think that's one of the challenges for health plans is how to best integrate and incorporate some of these community-based providers for their local expertise.
Mike, Linda, you both really are talking about whole person care, and I don't want the lack of coordination, I think, and the scale of it, whether it's dual diagnosis, alcohol, drug abuse, behavioral issues, more coordination is still better. But there's still a breakdown often in the coordination on the clinical side. I don't know, AnneBeth, whether you want to talk about that, kind of what the challenge is and how we start to think about solutions. Because while I'm beleaguered a little bit by the long list that Linda lays out, the fact that she knows about it and is working on it means we're making progress. But often that's as much of a challenge in the clinical setting as it is outside along the challenges that Mike was talking about. Do you want to speak as a physician about how you think about it and start to solve for that?
Sure, thanks. So I think you hit the nail on the head that the clinical people are speaking clinically and the community-based people are speaking, community and social determinants. And I think it's really figuring out how do you solve for that fragmentation and prioritize what the members' needs are, try to get to the core of what their need is, making sure that you're addressing the clinical needs as well. So care coordination, I think over the last, we'll say 5 to 10 years, has become the new buzz phrase. Everybody should have care coordinators, and we are getting better at it and definitely getting more coordinated with it. But I still think there's a lot of opportunity to be able to optimize who's care managing and what and how that whole person care plan is being developed, to make sure that the clinical people are taking into account obvious examples like diabetes. If you send in the best nutritionist, you give the people the information you think they need on how to manage their diabetes without asking, do they have access to food? Do they have access to, fresh fruits and vegetables? Do they have the ability to, do they have a stove where they can prepare a proper meal? Do they have the education to be able to choose wisely, even though they're giving the list? So I think we have to make sure that we go back to the core of the individual and address their needs in the context of their clinical, circumstances. So I think
even though the image may not be coming through, your content is coming through loudly.
Great. Okay. Right. I was garbled for a minute, so I appreciate that you can still hear me. So I think it's a work in progress, and I think what we are trying to do at CareCentrix is really being able to be that care management system where we have the opportunity to pull data from multiple sources and be able to integrate that data into meaningful opportunities for the member, meaningful outcomes for the members. So I don't know if you want me to talk a little bit about our predictive analytics and how that clinical, how the clinical and the community and the predictive analytics all can come together to hopefully move us closer to care managing the members' needs and helping them to overcome some of their the struggles and barriers that they're having.
Well, I think there's a lot of value in bringing technology around the prediction element, but I think in this particular case, at least the way we think about it, is we're in charge of care traffic control for other populations. In the case of the LTSS population, as Linda and Mike suggested, it's more care traffic influence, but taking that whole patient look and integrating data and analytics in. But speaking practically to the audience this afternoon, Susan and Scott, okay, you're the health plan advisors. How do they sort through it with the calm sophistication that Linda suggests that she's bringing to it? Like, what should they be thinking about? What are the challenges for health plans as they think about kind of being thrust into this population, in some cases by choice and in some cases by necessity, if they want to really work with state Medicaid populations? I don't know, Susan, perhaps you could take that and give Scott some time to prepare his answer.
Sure. Well, as Dr. Litt was saying, it's really important for the health plan to assess the whole person. I know that's a buzzword, the whole person or person-centered care. That's the latest buzzword. But you really do need to assess that individual's needs on the medical side, as well as the physical environment, their social environment, who are their natural supports, what kind of caregivers do they have, unpaid caregivers, what kind of support can those unpaid caregivers be given just to help out a little bit? And that can go a long way in helping the care manager, at the health plan to understand and really provide the most needed care for that individual. I think oftentimes health plans tend to medicalize the model a little bit more. They can, and maybe Linda, you can chime in, or Scott about this. Is my experience was that often care management would take a more paternal view toward the member and sort of medicalize, well, we know what you need, instead of being more person-centered. We really needed to emphasize the training for, well, maybe this person really doesn't want to stop smoking right now. There's other issues that they need to deal with right now, and how can we support that caregiver? So having that whole person assessment, I think, is a good starting point. But maybe, Scott, you can talk a little bit more about how that might help.
Yeah, I completely agree. There, a couple things that I want to add to this. I think you're right on. I think that if health plans take the traditional med management approach, it's not going to work for this population for sure. And I think that, Mike, when you were talking about housing in particular as being a challenge for these folks, I always laugh. Those of us that have been in Medicaid for so long, right? We've been doing social determinants of health work before social determinants of health work was cool, right? It's the buzzword now. But we've been doing that in Medicaid since day one, because we know that things like housing, food insecurity, transportation, all the things that we've all talked about on this call are so important to the overall health of the member. So I think that's the challenge for health plans, because, traditionally in Medicaid, we're used to managing TANF population, moms and kids, right? Linda, you're in a unique situation where you've got all the members in the plans, but in a lot of states, even on the CareSource side, right, our Indiana Medicaid population is all TANF. Our Georgia population is all TANF. So as we think about what it means to manage, an LTSS population, it is a whole different ballgame, because all those SDOH issues come into play. The way you do medical management is completely different, and making sure that you really, break down those barriers, coordinate all those services for the individual. And then the one thing you've heard, from all of the presenters today is to talk about the caregiver. Just as important as the member in this process is the caregiver. So I think that's the one thing on the health plan side, that if you're not familiar with managing this population, it's just as important to make sure that the caregiver, family member, friend, et cetera, maybe the member self-directing their care, that they have all the tools they need to make sure they're well informed on what the care plan is, how it's going to be established and executed upon, et cetera. So I think it's really bringing all those different pieces together that are important. And the one last thing I would mention too is, I think Linda said this very early on, the term LTSS is a broad catch-all term that includes, right, elderly with long-term needs, those with intellectual and developmental disabilities, children. So you have a variety of different sort of issues that permeate throughout this entire group of individuals, not to mention the behavioral health and SUD challenges that she mentioned as well. So it's a broad term, but it's a very complex group of people that if you're a new health plan or going into this population brand new, it's quite frankly unlike anything you've ever managed before. So it requires a very different approach and a different level of expertise to make it work. It can't be done well.
Yeah, but you're all calling out. I mean, I think, I love, Scott, if you're the social determinants of health is just the way healthcare interprets poverty and the structural inequities that have existed for a long time. And those of us who work with the homeless, like Mike and I did, or worked with the departments of mentally ill or disabled populations like AnneBeth, you realize that you need to both acknowledge the structural inequities and the challenges that folks have every day, but also build on family structure, cultural structure, neighborhood organizations. How do you do that start to do that as a health plan, Linda? You've got a lot of experience in that, but a lot of the new health plans don't have experience in thinking about this population and don't understand the integration of the community, the family, and the vulnerable individual.
Sure. It's really about getting out and knowing your community. Who is providing that type of service today? And many times these agencies are doing it on grants, out of the kindness of people's hearts that they've done. And so how can we as a health plan then really get out. So we can support you in that, not only financially, but we want to be a part of this to help to deliver the service. And we have found that, many of the things that we need for our members are not traditionally health plan benefits. And so, we're not paying for someone sending us a claim and we're paying for it. However, if, like today in Virginia, the heat index is 101 degrees, and you have someone that's confined to their home without air conditioning, in unique situations, we pay for an air conditioner, but sometimes we need to actually partner with a community resource to provide that. We have a large homeless population, so we have to look at cooling stations and all the other things that are needed. So we are actively reaching out and trying to find those community partners. What can we do to help you to continue your mission? When we started some of the services, for instance, the charitable and free clinics in Virginia did not take Medicaid. They were getting charitable donations. Many of our members actually, before they became eligible for Medicaid, they would go to the free clinics, and then when they became Medicaid eligible, they would continue to see them because they have that relationship with them, but they weren't taking Medicaid. And so when we really approached them, it really was about, we don't know how to bill you all. We don't know how to credential. Those are all administrative things that we can get over those hurdles. But the win for us was if we can partner with you so that, yes, you will continue to see our membership. They have such great wraparound services. So we can help you with those things. We can also help you establish your revenue, but you can continue to see our membership.
That's great.
The one thing I will say is a challenge for the health team when we first started to care for this population. It really was about changing your care coordination model. The model, of course, mostly was telephonic. Telephonic care management does not work for this population. You must be in the home doing face-to-face assessments, observing the family dynamic. So much of what's needed is, yes, I have a caregiver that's coming in that maybe not live in the home, but, we have observed elderly abuse, sometimes child abuse, by just being in the home in the observation. So I will say that is critical to helping this population.
AnneBeth, do you want to just build on that? Because there's that Linda really has given us, really the street level reality of caring for these vulnerable individuals. But talk a little bit about the power of some predictive analytics that can actually identify a lot of those care gaps, structural inequities, whether it's from a health equity point of view or a whole person point. They can help us point us as health plans and collaborative partners to kind of solutions.
So as Linda said, this patient population is way more than claims and social determinants, but being able to have big, broad, comprehensive data sets at least gives us a little bit of a fighting chance. And it's crucial for us to be able to link all those different data sources. So being able to pull in claims and assessment data and outcomes data, social determinants, even weather, as Linda pointed out, if we're not addressing the weather when it's 100 degrees and someone doesn't have an air conditioner, you can't deal with their diabetes if they can't breathe because it's 100 degrees and they're humid, uncomfortable apartment. So we need to be able to at least start at the community level and pull those various data sources, and that'll at least give you what's going on a community level, give you the, as everybody likes to say, the 30,000 foot view. But unfortunately with this population, as Linda said, you really need to get down on the ground and walk into that building and see what's going on, because the person on the 7th floor, for example, it's hotter up there than it is on the 1st floor. So that person may need more resources than someone who's on the 1st floor, who can walk outside and get a little bit of a cross breeze. So the predictive analytics is a great way to get us started in terms of being able to find out what's going on again, from a community point of view, because we can do it locally, we can pull in what's the weather, we can pull in, do people own cars, do they own their homes, who, are there large families living in small buildings, are they living in a food desert, are they living in a place where it's very challenging to get their medication. And so you can pull all of that data together, and then once you get it all together, you have your starting point, and then you have to really, take that and move to the members. So we can at least begin to look at who we are, who the LTSS population is. But again, we need to make sure that we're going back to the individual.
Well, it's the opportunity that data provides to do deeper personalization and honestly just to identify a lot of those challenges of structural inequity that are still barriers. But then you have to put the hands-on work that Linda and others were talking about. Mike, what we tend to go long on the challenges here. There are, I think, some tremendous opportunities around transitions or lack of transitions to care for this population. Maybe you and Susan could talk a little bit about the opportunities to influence and improve. Again, we got to balance the conversation between the challenges, which are great, but there's some relatively straightforward wins here if the care is coordinated in the right way, where you can predict where the opportunities are, but through the kind of data analytics, and then with passion for the populations, help them there. But maybe you and Susan could talk a little bit about transitions to care, because that's certainly where we see real breakdowns today.
Yeah, I think that when I think about this, given my state and federal perspective, I think about it as some of the policy opportunities that exist today. One of the things that, maybe the big elephant in the room, at least when you're dealing with the Medicaid population, is, kind of the bifurcation of Medicare and Medicaid, and the need to kind of bring, we're talking about whole-centered care, person-centered care at the individual level, but the interesting thing is the financing mechanisms are separate. And so, one of the things I think that a lot of states are moving to do is to better integrate Medicare and Medicaid services, and there are a number of ways that states are trying to do that. Whether or not that's through, and CMS is also supporting that, whether or not it's the financial alignment demonstrations or some of the work that is aligning DSNPs with Medicaid, MLTSS. But I think I kind of think about it as like that, one of the opportunities that I think states have working with the federal government is to kind of try to bring the financing sources together. I think CMS has also been very active recently in terms of social determinants of health, and they recently published a roadmap to allowing states to do the social determinants of health, which really includes some of the things around transition that I think are really important to consumers. That includes basically one-time community supports. It means for people who are making the transition from nursing homes or institutional care to home community-based services. It also means housing and tenancy supports for individuals who are making that transition, as well as home modifications. So CMS is certainly thinking along the lines around what are the policies that it can implement to help states facilitate transitions. And then finally, I would just mention, the big opportunity that I think comes with the American Rescue Plan funding that is being made available to states. And this is the 10% bump in the FMAP that's basically calculated off of home and community-based services for Medicaid. And states have a great deal of flexibility in terms of how they spend those resources. And one of the things that is identified in the CMS guidance around this additional funding is seeking ways to asking states or putting forward that transition services are one of the areas of support that potentially states might want to look at in utilizing these funds. So I think that there are a number of opportunities out there that states are moving to implement, and some new resources that are potentially available to states.
Well, there's some good news. Susan, what the thoughts on care transitions? Because I do think that's a really big opportunity, particularly given the fact that with data we can actually point out where things are failing today.
Right. And based on my experience when I was with a health plan, having those transitions go smoothly, as Linda was talking about earlier, and Scott from his own personal experience, can really impact the health of the individual for the better or for the worse. And we had some real challenges at times at the health plan to get the services for that individual in their home upon discharge from the nursing facility. And part of it was because of, in this case, it was state policy requiring that the Area Agency on Aging go out to the home and do the assessment to make sure that they were eligible before services could be provided. So it was sort of a chicken and egg factor, and the policy needed to change. But I'm encouraged that this is being addressed in many places, that this transition of care is a really important crux in the care of the individual, and having all those supports on day one when that individual leaves the nursing facility, gets there, has their services. And I think that's encouraging, is that health plans and state policymakers are realizing that they come together and work on solving these issues. Coordinating the care, Mike, I think, touched on this, between Medicare and Medicaid, can also be very challenging, as that, for example, Medicare pays for wheelchairs, so does Medicaid, but under different circumstances. How do you coordinate that? And so we're seeing more and more integrated type programs coming on board in the states, not just those financial alignment demonstrations, but using dual eligible special needs plans to help integrate with the Medicaid plan, and having a quarterback. And maybe, Linda, you have this where there is a lead person on the team that is caring for that individual, a quarterback, if you will, that kind of leads the multidisciplinary care team, so that they're the go-to person, and there's that level of coordination. But maybe even, Scott, you could talk a little bit about that too.
Yeah, I completely agree. I think that everything you said, resonates with me, and I think the one thing too that I wanted to go back to is that Linda made a comment early on about, like, once somebody goes into a nursing home, the services kind of dry up if they come back home. I think in some of the markets that I've worked in, sometimes those services aren't even there to begin with. So whether it's personal care services, private duty nursing, those sorts of things that, a member relies upon, that's one of the struggles the health plan has, is just trying to find those individuals to get into the home, to care for the member in the home, et cetera. So I also think too, one of the other comments I wanted to make as you all were talking, I know in some of the markets that I work in today and I've worked in previously, the states are allowing or being a little more creative around the use of Z codes, for example, to allow plans to bill for things that are non-traditional, to capture some of those social determinants of health type work that we do, like the air conditioner that Linda had mentioned and that AnneBeth talked about as well. So, but I think you're right. Like, having someone to quarterback, that's always the challenge I've had as a health plan leader, is, you have a nurse at the health plan who maybe has 50 individuals in their caseload or less, depending on what the state contract is. But even that ratio itself, right, 50 people, all of whom have needs, can be a challenge. So making sure that you support not only the nurse care manager at the health plan with those community-based organizations, all the services you need, we always tried at the plans I've worked at to make sure that we have different parts of the organization trying to help that member find that provider if they need one, get them the care from the community that they need. And Linda's right, it's a big-time ground game, not only with the member, but the CBOs that are providing the services, to make sure you make all those connection points. So I think everything that, Mike, you mentioned I wrote down your
Community-based,
quotes.
community-based organizations, not the Congressional Budget Office, because Mike could get confused.
Yeah, sorry, that's right. But I like what Mike wrote. Mike said, I wrote it down because I'm going to use this. We talk about home person care and holistic care, but the financing mechanisms are different. And that's a great point, because trying to figure out what Medicare covers, what Medicaid covers, when does what kick in, we have a hard time even, I think, as plan leaders trying to figure all this out, let alone being the member that's dealing with this day to day. So I think we are moving in the direction where it is getting better. It's getting more integrated. And I think if we really want to make a difference, that's got to continue. So we're moving in the right direction, but albeit slow, it is happening.
Linda, one of the things you said, which I was, again, building on Scott's point, was, that the longer you're in the nursing home, the more that it's almost like the capillaries start to dry up of support. But gosh, often I think that a lot of those nursing home stays are avoidable if the capillaries are strong. Do you want to talk about, because that's where there's an economic and I think a healthcare win, because a lot of folks coming out of the nursing homes are more debilitated, both because of their support networks gone. And I think we could avoid the stay completely. And for me, that's one of the big opportunities of executing along the lines that you talked about. But if you could talk about that and like how big an opportunity we have and just keeping people out of institutions, which even when they're well run, sometimes can be pretty debilitating for a lot of these vulnerable populations.
Absolutely. And I think it not to beat this to death, but it goes back to the early identification of the needs of the member and your intervention. It is almost too late if you're identifying someone in need once they hit the emergency room or they have a hospital admission. And unfortunately, sometimes we have Medicaid members who that's their first entry into long-term services support. They have a hospital admission. Now they need to go into a nursing home. They get a screening, and then they become eligible for a waiver. The waiver puts them in long-term support. So, we need to do some pre-work actually on our regular Medicaid side as well, because many of those members then turn to that population. And so I think it's really about the predictive analytics, understanding who's high risk, who has manageable conditions. Are there conditions that we can intervene early and help the member to manage their own condition? But do we need to have a focus on some of those that are high risk with a little bit higher approach, such as maybe having a network that you have in-home physician and nurse practitioner support. Sometimes where people live, we are in the state, across the entire state. Some areas are very urban, but some are very rural as well. Really? And even though we provide transportation, it is still difficult for some of those members to get into a physician's office. And so they put off until they are in a state where now, they really need the care. The other piece is the transitions of care. We find that medication adherence, and not just adherence, but really getting that medication filled at the time that a person is discharged, making sure that they understand how to take it, when to take it is important. So we actually started a program that within 3 days of discharge, not only happens on the transitions, but within 3 days of discharge, there is a home health visit, a care coordination call to find out, do you have the follow-up visit scheduled? Do you have transportation? If you cannot go into the physician's office, can we set up maybe a telehealth visit? And then lastly, did you get the medication filled, and are you able to tolerate it? Because we're finding that sometimes people will get the medication filled, they take it for a couple of days, and it makes them sick, they have upset stomach, or whatever it is, they stop taking the medication.
Oh, no
we
question.
have found that 7-day readmission, 30-day, the biggest reason for that is medication, because they stop taking the medication. And so we found that it's important to prevent those people. And if you don't get on that soon, then of course it's ER visits, it's hospitalization, and it continues to repeat the cycle until they end up, the family gets frustrated and think that someone going into a nursing home is the right answer.
No, Linda, the whole the superpower and danger of the assumption that people who are prescribed a script are going to take it. It's about a 30% actual closure, and a third of the folks who aren't taking it is because they get it, but they can't tolerate it. It's a very powerful point you're making, and they're often, if you know that, you can move scripts around, but folks aren't even checking, and the patient wouldn't necessarily know. And I also think that the predictive analytics are very powerful, but we also find you have to kind of build in some of the structural, some models that acknowledge the health inequities that are structural in order to make sure you can identify where you need to build a bridge that doesn't exist. Susan, perhaps you could talk a little bit about assessment, because all folks on this call are very thoughtful about the complexity of the needs, but there's an important role of assessments early on and continuously to make sure we're tracking with kind of the whole patient needs to get the whole patient care right. You want to speak to that a little bit?
Sure. Well, we talked about it a little bit in the beginning about assessing the whole person, and that includes not just their clinical needs, what medications they're on, but addressing their social needs as well. And I think and there are some assessments that include assessing the caregiver, and Linda touched on this. What are the caregiver's needs? And if you can help support that caregiver, that can help allay a lot of the acute episodes that the member may have, giving them some support so that more personal care hours aren't needed, or maybe bumping up the home health work a little bit, or bumping up the personal care may avoid an acute episode. Maybe including the community resources for food, getting a food bank tied in for the individual so that they have access to food. So these assessments are vital, particularly when you're at the health plan and a member is first becomes a part of your health plan. You really need to get a good read on the member. And I know that when I was with the Florida Department of Elder Affairs many years ago, we really looked at those assessment instruments and made sure that those assessments really addressed all aspects of the individual's life, what medications they were on, what services they were getting, what natural supports they had, and paid and unpaid care. So I think having those assessments in the system electronically, being able to share the data between other providers that you're working with to coordinate the care. So I think data sharing is really a vital part of having an assessment, being able to share it with the other providers, the primary care, the personal care worker, home health agencies, to be sure that they know what's going on with that member. Linda, do you have any thoughts about that on the assessment? I'm sure many states prescribe what type of assessment instrument is used, but then health plans often have their own health plan that they also use to embellish.
That's correct. And there are usually required elements for the assessment. But I mean, for me at least, we can also include additional questions that we have found to be helpful for our population. I know we haven't talked about the home modification piece, but I think that is also really critical on the assessment as well, because that can be key to keeping someone in their home. And I think most all plans have a home modification benefit. It is challenging to find a network sometimes to be able to complete those modifications, depending on what it is. But that has been really important. Sometimes it's just, I need a ramp so I can get in and out of my house. I need something to help me with being able to get into my bathtub or my shower. So the assessment piece is the first step. And, I also just wanted to touch on, I think, on the communication and the support for the care team. A lot is put on the shoulder of the care coordinator. I laugh sometimes and say, we expect these people to be, almost like miracle workers. But they have to have the full support of maybe community health workers, social workers, We also support them through our call center, through our member operations. We have a separate long-term services support call center that can take those calls that have been trained really in the unique needs of those members. We find that the talk times are longer, but also they have a connection, direct connection in with our care coordinators, so that when they have someone on the line who really has a need, they can get them directly over to a care coordinator. We also find that where possible, if you can keep the same consistent care coordinator, we know there's turnover, people leave, but when possible, keep the consistent caregiver. It builds trust with the member, but also then they know that person and can help them. And they also usually can head off any adverse events that are coming up if they're able to see that earlier on.
But it's very powerful, Linda, when you've got that level of commitment and connection between the health plan, the care coordination, and the silos of care. I mean, I've got to think, as a doctor, AnneBeth, you've run into the even where there's a rich amount of resources, it's not being connected across the different non-clinical and clinical, as well as Linda has woven it together for her plan.
Agreed. I think where we find the greatest success is when the care coordination is going on in the community. So a lot of times within the provider practices or within places, these members feel comfortable. So to Linda's point, making sure that we are meeting the members where they are and providing those resources in a way that they can receive them. So it's hard. I think with it being community-based and having those, those miracle workers, the ones, peer advisors and peer advocates that are on the ground, who are walking the same streets, who are living in those environments, really are able to build the greatest degree of trust and have the most successful interactions, and I think are very motivating they're relatable and therefore motivating to the member to, to the patient, see that there's an opportunity to, they have their advocates, they have their supports, and therefore they can more positively move forward.
We've laid out a lot of the challenges, and we've got only a little bit of time left, but maybe we'll do a lightning round of, why are you optimistic about caring for this population? And Scott, tell me, you're optimistic about everything, but you've taken this on, you're passionate about it, as has everyone on this phone. Tell me why you're optimistic.
Well, I think that, having been in this business for so long, there have been a lot of changes recently that I think are moving us in the right direction. I think the recognition of social determinants of health for this population and how important it is, that is a big change from what it was before. Being able to bill for things like air conditioners, wheelchair ramps, those sort of non-traditional type things, that's a change in recent years that you're now allowed to do to help with these folks. And I think, the other thing too that keeps me optimistic is that there's a big push now for self-directed care. What does the member want? What are their needs? What are their goals? What are they trying to accomplish? Healing and aging in the home, like you mentioned early on, John. Making sure we put that member front and center. Again, we've been doing this in Medicaid for a long, long time, this holistic view to sort of make sure we understand what the member's looking for. But I think all of us on this call that have been managing these folks or working with these folks over the years, we have many, many stories, success stories, right, of people that we have helped over the years to get the services they need, care they want, et cetera. And more states nationally are looking to move these individuals into managed care. So I think there's a great story to tell. There's a lot of great work that can be done, but pulling all of this together to put that member front and center, make sure they get the care they need, that's where we're going. And I think, again, there's a lot of new tools, a lot of data that's out there that will help all of us manage these individuals in the future. So I think it's the right thing to do, and I'm excited about kind of where we're headed.
Well, I'm really enthusiastic given all the ideas that are on this call. I just hope that it can weave its way into managed care across the country, because from a managed care perspective, health plans, hear me now. This population is coming. If you're going to be in care, you're going to be managing the most vulnerable population. And at least I think all of us on this call recognize that it's enormously rewarding to have those wins that Linda and Susan and Mike and Scott and AnneBeth are talking about. And I just want to thank everybody for keeping the faith, staying passionate about this population, coming up with ideas and leaning in and sharing some of your insights with the community and with the folks on the call and folks in managed care, because a lot more care needs to be managed in a way that represents the unique needs of the population, of this most vulnerable population. I'm really excited. So thanks, everybody.
Thank you.
Thank you.
Thank you.
Thank you for that great presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.